Hi everyone, I'm Grace. I'm in Group 8, and our project is titled Treatment Planning Balancing Evidence Based Medicine with Individualized Care. Our team, Miranda, Jacob, Elena, and I, explored how healthcare professionals in different specialties design treatment plans that combine standardized evidence based guidelines with the flexibility needed for real patients.
So our team's case study explores how healthcare professionals develop and personalize treatment plans while balancing evidence-based medicine with individualized patient care. So we chose this topic because healthcare today depends on technology, data, and evidence-based frameworks. Yet even with all these tools, recovery still depends on judgment, empathy, and personalization. So our goal is to understand how professionals in medicine, therapy, and nursing can balance standardization with individuality and how engineering systems like clinical decision support can help them do that. So we interviewed 8 healthcare professionals from different disciplines and countries to capture a wide range of perspectives.
Evidence based medicine, or EBM, means making clinical decisions by combining scientific evidence, professional experience, and patient values. Our interviewees all emphasize that standardized evidence is necessary. It gives structure and safety, but real patient care happens in the gray areas. For instance, Dr. Jenny Pacheco, an anesthesiologist from Venezuela, told us she viewed EBM as a proven recipe. She follows protocols like those in the Enhanced Recovery After Surgery program, which outlines steps for pain management, nutrition, and mobility. But she always adjusts based on the patient's emotional state, pain tolerance, and age. She said, "Science is the map, but the patient is what guides the physician through that map."
Clinical Decision Support Systems, or CDS, are electronic tools that give real-time alerts, reminders, and recommendations. Every healthcare worker we interviewed uses some form of CDS, but how they use it varies. For example, Jennifer Harms, a urology nurse, explained that her EMR system alerts her to changes in lab values like creatine or urine output. Those warnings help her detect early signs of infection or kidney injury. She also gets alerts about drug interactions or allergies before administering medication, which prevents errors in urologic procedures. But she admitted that alert fatigue can be a real problem. Sometimes the system sends so many notifications that it slows workflow. Still, she told us it's better to have one extra alert than to miss something important. Similarly, oncology nurse Leanna Trimble uses CDS in chemotherapy administration. Her system flags incorrect doses, drug interactions, and abnormal blood counts before treatment. She said those tools are life-saving, especially when working with potent drugs like chemo agents. However, she also noted that too many alerts can interrupt the rhythm of care.
Value based purchasing, or VBP, is a system that rewards providers for quality of care rather than the number of procedures performed. Occupational therapist Lloyd Munson explained that his hospital receives a fixed amount from insurers for each diagnosis, for example, a shoulder surgery or hip replacement. This pushes therapists to use their session wisely because if a patient stays longer than expected, the hospital loses money. Munson says that this system encourages efficient, focused care where every session must have clear purpose and progress. He also mentioned that for post-surgical patients, he follows physician-directed timelines, like specific exercises allowed at week 2, 4, or 6, but adjusts them depending on pain or swelling. Meanwhile, in Venezuela, Dr. Pacheco said healthcare is transactional. Providers are paid per procedure, not by outcome. Yet, she and her peers still strive to connect their work to real patient well-being out of ethical duty, not economic incentive.
We interviewed professionals like oncology nurse Liana Trimble from Lakeland Regional, occupational therapist Lloyd Munson from Lee Health, urology specialists Dr. Scott Martz and nurse Jennifer Harms, anesthesiologist Dr. Yenny Pacheco, physical therapist Simon Cadero and Anna Julia, and ophthalmologist Dr. Paula Ciramelli. And each one of them described how they used guidelines as a foundation, but then modify them based on patient response, context, and available resources.
Every interviewee emphasized that standardization and personalization coexist. Jennifer Harms described how in urology she begins with AUA and NCCN guidelines for procedures like catheter care or kidney stone removal. But those protocols often need adjustment. For instance, patients with heart failure can't follow the usual hydration instructions, so she modifies their plan to avoid fluid overload. She also adjusts pacing when patients experience anxiety or pain. emphasizing empathy alongside data. Dr. Martz, her supervising urologist, shared a similar mindset. He follows strict AUA and NCCN treatment frameworks, but said, medicine is both a science and an art. The data guides us, but the patient defines the direction. He might recommend surgery for one prostate cancer patient, but prefers active surveillance for another older patient with comorbidities. Likewise, physical therapist Ana Julia said standardized rehabilitation techniques like electrotherapy, cryotherapy, or thermotherapy are useful starting points, but she always builds personalized plans around each patient's functional limitations and daily life challenges.
Lloyd Munson follows physician-directed post-surgical protocols. He personalizes care based on the patient's pain, swelling, and progress. He says, I could see 4 rotator cuff repairs in one day and all of them will be different. Clinical reasoning is used to adjust plans such as modifying rehabilitation exercises or changing the treatment frequency. All interviewees agreed that communication with all aspects of the care team is critical for safe individualization of treatment plans. Mon Cordero, a physical therapist from Venice, explains that he starts every case with detailed assessments, then applies standard post-surgical guidelines such as therapy frequency and progression timelines. For example, after a knee replacement, he typically sees patients 3 times per week for 2 weeks before transitioning to outpatient rehab. However, if the patient's recovery is delayed due to age, home environment, or comorbidities, he works with the physician to extend therapy or to modify goals. Cordero also highlighted patient education as crucial, saying that most patients align with their plan once they understand it. When expectations are unrealistic, he uses re-education and collaboration with family members to reset goals. Ophthalmologist Dr. Paula Ciramelli told us that visual rehabilitation often follows standardized post-surgical steps, but for aesthetic rehabilitation like prosthetic eye fittings, everything must be customized. Each patient heals differently, so she adapts techniques according to how the ocular surface responds. She said that structure and flexibility must move together. Standardized care ensures safety, and personalized care restores humanity in the process.
Ethical and legal factors were central to every interview. All professionals highlighted the importance of patient autonomy and collaboration. They believe patients and families should participate in setting goals and understanding expected outcomes. Cordero said the shared planning process is an ethical obligation. The patient isn't a passive subject, but instead an active participant. He also discusses legal requirements like documenting that home care patients are homebound and meet Medicare's criteria, which ensures fair and justified treatment continuation. Jennifer Harms and Leanna Trimble echo this idea, explaining that standardized reassessments and consistent documentation help defend clinical decisions ethically and legally. Trimble also notes that these assessments prevent unsafe discharges and reinforce the principle that care must remain both data-driven and humane.
Every healthcare professional relies on evidence-based guidelines specific to their discipline. Occupational and physical therapists base their plans on physician-directed protocols and insurance visit limits. Urology follows AUA and NCCN standards. Oncology depends on NCCN chemotherapy regimens that specify doses, cycles, and lab criteria. And Hope Care therapists use OASIS data collection to evaluate outcomes. And despite the structure, they all said flexibility is essential. So Leanna Trimble described having 3 patients on the same chemotherapy regimen, but each reacts differently. Some experience nausea, others don't. She and other oncologists adjust dosing schedules or delay sessions dependent on tolerance. So these examples show that EBM, evidence-based medicine, provides the map for treatment, but each patient's biology and emotions define the path.
Dr. Martz uses CDS systems to check whether imaging tests or medications are safe for each patient's kidney function. The system automatically warns him if contrast dye could cause harm or if antibiotics could worsen renal issues. Leanna Trimble's oncology software works similarly. It flags low neutrophil counts or incorrect chemo orders before infusion. She said, I'd rather have an extra step in the process than risk a chemo dosing error. All participants agreed that CDS has improved safety and accountability, even if some alerts are repetitive. As Dr. Martz put it, When the system tells me something clinically meaningful, it's invaluable. When it tells me 20 things, I already know it's a distraction.
The interviews related two very different healthcare economies. In the US, outcome-based systems like value-based purchasing push clinicians to maximize results efficiently. At Lee Health, Munson's therapy schedule is tightly budgeted by insurers, motivating his team to focus on measurable progress each session. Jennifer Harms connected her unit's infection control success to hospital bonuses tied to readmission rates and patient satisfaction. In Venezuela, though, doctors like Dr. Paccio and Dr. Ciarmelli operate under transactional models where pay is disconnected from outcomes. Yet both express that true professional fulfillment comes from patient well-being, not paycheck size. Ciarmelli also mentioned how low pay undermines motivation, arguing that fair compensation should reflect skill, education, and responsibility.
Despite the differences in setting, everyone agreed that outcome-driven systems improve care when they balance efficiency with compassion. These models motivate clinicians to make every session count, reduce unnecessary procedures, and educate patients for faster recovery. Still, they warn that pushing too hard for efficiency can risk depersonalizing the care.
In conclusion, all of our interviewees reinforced the idea that the future of healthcare lies in combining structure with humanity, standardization to reduce error, personalization to improve outcomes, and technology to strengthen both.
We learned that data alone cannot replace human empathy, and intuition cannot replace evidence. The best care happens when both are integrated through thoughtful systems design.
Our reflections also emphasize the role of engineers in healthcare to build tools like clinical decision support and AI that complement, not replace, human judgment, and to create systems that make personalization easier rather than harder.
Ultimately, as Dr. Paccio said, science is the map, but the patient is the compass. That simple sentence captures everything our study found. Evidence guides care, but human connection gives it direction.